Hi, Dirk. How are you? And great presentations. We've been enjoying really listening to the debate as well as all the great presentations. So we've got a case here which we should be able to do quite quickly, but it's really got a lot of thoughts that were expressed, especially in the debate in this case. So I'm going to introduce our team. To my right is Dr. Karthik Guja, our Associate Director of Endovascular here at Mount Sinai. To his right is Dr. Sardar Farhan, who has come all the way from Austria to train with us. He did an interventional cardiology fellowship, and now he's doing his endovascular fellowship with us, and he's been an incredible addition to our group. Behind is Ashley, who's our RN, and Cristobal, who's part of our traditional team here, and we have some people from the IVIS team as well. So I'm going to have Sardar just present the case, and we're going to go very quickly through it.
Good morning, everybody. Our patient is a female, 84-year-old. She has the classical risk factors of hypertension, hyperlipidemia, and diabetes. She presented to Dr. Guja's office with severe claudication, bilateral, however, left more than right. And she had, as you can see in this slide, reduced ABIs on the left side, more significant than on the right, with 0.62. And she is an elderly lady with heart failure and reduced ejection fraction, and she was deemed as high risk for surgery.
So Dirk, just a little bit more history. I was talking to Dr. Guja to give you guys a little bit more background. So this is a lady who presented with critical limb ischemia of the right leg, has bilateral known common femoral artery stenosis, which was medically managed because of her surgical risk. So Dr. Guja fixed the right common femoral after she was declined because of her surgical risk via the radial approach. And you can see the angiogram. This is done about 3.5 months ago, where he did a directional atherectomy. It was calcified, but not as calcified. And he did an impact balloon, a 7.0 by 40. And you can see he's got fantastic results, and the ultrasound follow-up has been good. In the meantime, we left her left common femoral artery alone, and now she suddenly, over the last month, has developed progressive rest pain. At the time of his angiogram about 3 months ago, she had a tight SFA stenosis distal at the level of the POP, and she had a 99% common femoral. So and the ABIs are older that we just presented. When you see what's happening now and what's changed in the time while we were preparing the case for our conference, you can see that she has a tight common femoral stenosis, which was old right there, which is, again, not involving the profunda bifurcation, and is below our inferior epigastric artery. However, when you look at the SFA, you can see that this is another picture. Go next, please. You can see that the SFA has slow stenosis. She has rest pain. You can see that the profunda fills, the SFA fills, but keep going, next. SFA has multiple areas of stenosis, next. And then in the last, I'd say, month and a half to 2 months, she's gone on and occluded her distal SFA at the level of the popliteal, and you can see by the flow. So at this stage, she has two-level disease. She has two-vessel runoff to the foot. She has two-level disease and now has progressed to rest pain. So at this stage, we're feeling that opening the common femoral at her age, she is elderly, but she's active. I wouldn't say quite active, right? She is active. And the issue is whether you think opening this would help. In our discussions with our vascular surgeons here, we feel like it likely will be possible to open this and will help her do better. So I thought in light of the debate, this would be something that we could do. And so that's kind of where we're at.
Yeah, so really a complex patient. So anybody who wants to comment on the strategy, Chris?
Well, I think you have to make a decision up front whether you're going to treat both or not. I think when you use a common femoral artery, I usually like to use distal protection if we're going to do it. This looks moderately calcified at least. It's fairly proximal common femoral artery, and it spares a bifurcation, which gives you more option. My strategy would be one of the two atherectomy strategies with distal protection, either be a biggest jet stream, 2.4 to 3.4, or the Silverhawk, followed by atherotomy and then drug-coated balloon with a 7 drug-coated balloon. And I think this lends itself to a Sapera 6.5 bailout if you're going to do that. And the only other question is stage it like he's going to do it, which would allow you to do it from the leg.
Yeah, I think that it also depends on what you're trying to treat. If you're treating her claudication, you probably do have to go for both of those levels. If you're just dealing with the rest pain, trying to get her out of rest pain, probably either one of those levels, treating either one of those levels will probably do the trick.
So for the sake of time, I just want to tell you what we decided to do. We did an IVUS, and Brian, our thought process was similar to yours, and like Chris said as well, is get her out of rest pain. You know, so she's an elderly lady with having severe pain. So we decided to just open the common femoral, and obviously she's had a prior hip replacement. She's got other things going on, but not that they'll be preclusive. It's her EF that was the reason they didn't do. So here you can see the intravascular ultrasound that we did. Can you show the IVUS, please? So the intravascular ultrasound, play it. So when you see, we put the IVUS in the level of the profunda and slowly pull back. And you can see at the level of the lesion is heavy calcification. It seems to be eccentric calcification that you'll see as we come back right there. And now it's circumferential at the level of the common femoral stenosis and pretty much around the IVUS catheter. So hemodynamically, this is going to be quite significant. So at this stage, we decided to use a filter, and I guess this is kind of the question. In our feeling, calcified lesions, we published our series of 560 patients in JACC interventions regarding the use of filter in atherectomy, and this is the kind of lesion we feel embolizes, and at least in our hands. So we found that putting a filter here would be good. So we decided to use an Abbott EmboShield. Show the EmboShield, please. We decided to use an Abbott EmboShield at the level of the profunda, and that's kind of the reason why I wanted to ask what you guys would have done. We decided to filter protect the profunda because the profunda is what's giving collaterals to the leg, and I don't want to knock off that collateral. If you remember the SFA picture, the collateralization occurs at just after the occlusion. So I think that this would be better served with a filter here, and we're planning on doing a jet stream. So we're going to go ahead and get started with the jet stream while you guys talk. And so we're going to go blades down and blades up. So as you know, this is a 2-4-3-4 jet stream rotational atherectomy. And now we're going to go at the level. On, please.
So I would comment here. You know, based on what Dr. Kump said, you know, why would you not just stent it? Why not just primarily stent this lesion? You're above the profunda. You're not going to jail the profunda off. And based on that, why go through the expense and potential risk of embolization when you could just do a primary stent, take care of the lesion, and then go back and do something with the SFA?
So in this calcium, what stent would you use in an 8 millimeter? It looked like his IVUS was 7.5, 8.
Yes,
Yeah,
yes.
8.
I think you could use almost any of the self-expanding stents in that region.
Work it out. So we had done 2 runs offline, Mike, but I think that's a good point that you bring up. So, well, you know, our idea here is, yeah, she is elderly, but at the same time, if we can get away without stenting, and she did such a good job at the contralateral leg, that I think it's probably worthwhile not to go ahead and put a stent if we can get away with it. The other thing is, unlike Dr. Kuhn's paper or his presentation where Deleuze talked about Supera, he had the availability of the 8 millimeter Supera, which we don't. So, you know, we're bare metal stents, as good as they are, I think at this level, I don't know what the panel thinks, I would like to get away without stenting. The question is whether we should do a GCB or not, and then see how it turns out. But I'm going to take a picture now. We did do 2 runs offline, because I know we're running behind. So you can see here, that's just with jet stream atherectomy. And we're going to do a better picture here. Sorry about that. A little bit of, guys, get the IVUS ready, please.
Yeah,
Okay.
So,
Go ahead.
I mean, PK, maybe to express my personal opinion, I think there are, many of common femoral artery lesions which we encounter are actually more complex than this one, right?
Yes.
I think this is probably the most focal lesion you can get, except maybe you can get it with a little bit less calcifications in very few cases. But I would agree completely with Dr. Backrach has said. I mean, this is a very straightforward lesion for a scaffold. I mean, if the bifurcation is involved, placing a scaffold is many times not possible, or there are a lot of arguments why we should not want to have metal here. But here, very clearly, I think the only limitation I see is the limited size matrix of the Supera over here. But other than that, I think if you to me, that's a straightforward stent case.
But Dirk, just a counterpoint to that. If you can get away without placing a stent, why place a stent?
Yeah,
Because
but what's the disadvantage? Because I mean, you're making. I mean, the procedure is more complex. You have the potential for disc embolization and so on. It's more costly, probably, and let's say the long-term aspect of the recoil, since you can only remove part of the calcium, is still questionable. I mean, you showed a good short-term result on the other side, but I mean, it doesn't mean that this is. I mean, there's also no guarantee with a stent, but at least. Yeah.
But
I don't really get the point. You know, if you have a lesion which is perfect for a biomimetic stent, so why is having not a stent an advantage?
I think here we don't have the size available. So the biggest one we have is 6'5". So that's one of the reasons. Let's do a recording. So we would have to put a nitinol-based stent here, an 8.0 nitinol-based stent. And here you can see, as we come back with the IVUS, you know, we've got very good luminal gain.
So
See,
PK,
look at the
I'm going to
luminal
join.
gain. That's the lesion right there.
Dirk, I'll take the pushback side as well.
Look at that.
I think all the things you're bringing up, Dirk, are you're thinking acutely now. You're thinking of the short term, but we don't know the long-term results of Supera or any other stent in the common femoral. And again, to highlight the fact that the
what's the
surgical literature
vessel
is
size?
5 to 7 year literature, where everything endovascular is shorter than that. And I actually think Superas do very well in the common femoral if appropriately sized. So I wouldn't necessarily hesitate to use it if I was going to use a scaffold. But at the same time, there's an advantage to not leaving metal behind in a place like this where you have the flexion and all the calcific forces, because failure over time of atherectomy is something that can be fairly easily retreated, both open and surgical, open and endo, whereas failure of a stent in this area can really change the outcome of the patient.
And also, just a point to that, I mean, I completely agree with Dirk and Dr. Bachrach's point. I mean, it is a good point. If we had a good stent in America, at least, I know in Europe you guys are so lucky you get these stents a little early. But here, you know, we'd be putting a stent that really does not, really belong in this area. And I think that's what my hesitation. I think that's good right there.
So PK, I just want to comment. I think both your angiogram and the IVUS look beautiful after atherectomy run with a 3.4 device. That angiogram looked beautiful, and the IVUS you got a pretty good luminal gain there.
We doubled our lumen.
Yeah, and I'm with you, quite honestly. I wouldn't put a stent here either, just so that we're balancing on the podium here. If you can get a beautiful lumen and add drug to that and take out the calcium with a lumen without a dissection, I think you're doing a good thing.
Off-road map. The question is, what drug would you use? Do you use a DCB or do you do a POBA since it's a calcified lesion?
Look at that expansion, beautiful.
I would use 7.0 DCB, although this is 8. The other option would be lithotripsy, which we didn't discuss here, and maybe there you wouldn't need the distal protection if you're trying to save cost. I don't know. Dirk, do you use distal protection if you're using lithotripsy or lithoplasty, excuse me?
No.
Yeah, we haven't seen much
But you have it
embolization.
already, I think. I mean, there's already distal protection.
And I think it's important to add in here that if we were to have an appropriate size vessel at 6'5", for the Supera, I think you'd still would need to go in and atherectomize, because I don't think you'd get adequate expansion of the stent and probable elongation, which would be an ultimate problem with the Supera if you're not adequately prepped.
So right now, just to let you guys know what we're doing a 7.0 by 40 Lutonix balloon. And it went up very, very easily. Well, not at all high pressures. We're at nominal with nice expansion of the balloon. We're going to let it dwell for 2 minutes, but I want to just continue this discussion. So the reason we picked this case, Dirk, is that this is the kind of case that I believe at this stage, at least in the U.S., we can tackle endovascularly. I mean, obviously the bifurcation, I defer to Brian as well here to talk about from a surgical perspective. But in this kind of case, without a bifurcation lesion, if you can get away with saving this lady from having a surgical incision and provide her some durable results at her advanced age, I think we're doing this young lady a service. So I guess for me the worry is without a Supera that's an 8.0 Supera, I would find it difficult to put any bare metal stent. I know that we've seen images of access through nitinol stents and so on and so forth. But here, we just showed a case. I know it's only a month and a half or 2.5 months old, whatever it was, on the opposite side that we were able to get access. I think that we preserve the access side and hopefully we get her out of rest pain. So this is kind of the reason why we presented it. We know it wasn't technically challenging, but I think there was a lot of decision making here that really affects the real world interventionalists.
And I think Dirk and Dr. Bacharach, I think the main reason of not stenting her on the other side, my reasoning was she has cardiomyopathy, very low flow state. She has a SFA-CTO even on the right side. I just felt like, for a low flow state patient, 84-year-old, stenting her, if she has an outflow, if she still has an outflow disease, SFA-CTO, if she has any issues with that stent, now I'm causing her more trouble here than anything else. That was the main reasoning behind not stenting.
But those are great points, though.
I think that's a good
What's the
point
time?
as well, that we're having
2
an
minutes?
impaired outflow here, so that convinces me 50% at least better.
Those concerns are
But I agree, PK, I think it's an excellent case because I think it is really a very favorable case for endovascular in general,
Yeah.
whatever,
Yeah.
whatever you do. I think many of the cases are probably more complex, involving the bifurcation, and can still be done with the concept you suggested, atherectomy plus DCB.
I'm going to ask this question and then hide behind Brian over
No,
here.
let's leave
Was
it
there
there and take a
any
picture, just in case
consideration of
there's
a
a
hybrid approach here where you do a cut down to fix the common fem and then go endo to fix the distal SFA into the pop?
Walk it up.
Any thoughts on that? Would anybody take a hybrid approach here?
In what way would that be a hybrid approach? I'm just curious.
So a cut down approach to do an endarterectomy at the common fem and then go endo for the SFA.
Well, I think it goes back to the goal of therapy. And right here, since we're not really concerned about our claudication, let's get the filter. We really just wanted to get her out of rest pain. I think, Peter, it's a great point. But I think if we were planning on doing a cut down, I think then we could definitely would be treating her claudication rather than her rest pain. So I think here we were able to get a good result. You can see the filter does have a little bit of debris in it, and you can see the profundo flow is now brisker than the SFA. And we're going to capture this filter, and we chose an EmboShield because the EmboShield, it works very well in our hands with the Jetstream device. So we've actually shared our data with Abbott in terms of using it with the Jetstream, and we've had no retraction of this device, while using the Jetstream atherectomy. So it's another effective way, and I think I just want to do a quick IVUS offline. Actually, we should do an IVUS before we do this. Yeah, let's get an IVUS, and then we'll stop the case.
So PK, I think you really achieved a remarkable result here with the Jetstream. However, I mean, it is a very eccentric calcified lesion. So how do you make the decision between a rotational device like the Jetstream or a directional atherectomy device?
You know, Dirk, that's a great point. I mean, I just want to tell you our algorithm. In common femoral in our hands, we feel the Jetstream is the most effective device. With directional atherectomy, because of the tortuosity of the iliacs, we have difficulty. We have to retract the sheath in order to actually get the toggle of the directional atherectomy device. So with the Jetstream and these type of eccentric calcified lesions, we like the Jetstream. I know Chris has a lot of experience using CSI, and I think that's definitely another device that could work here. But however, with the luminal gain, we really like the Jetstream. So eccentricity of the plaque doesn't bother us. Now look at the luminal gain there. That's our lesion. So we almost tripled our luminal gain here, and with IVUS, and we're very, very happy. So we're just going to capture the filter, but that's our algorithm here, Dirk. It really works well. I don't know what the panel does in terms of atherectomy. I know Brian has tremendous experience with directional. I would love to hear his comments.
Yeah, I do like directional for these cases with the new Hawk ones. They actually do a very good job in the common femoral. That said, if you're protecting your profunda, you often don't have room for the nose cone proximal to your filter. And then the issues you described with the iliacs are certainly true. You got to pull that sheath back to expose the jog. So there are some challenges to using directional as proximal.
So Dirk, I think you saw the final picture. Can go C- while we capture the filter and send it to Andre, because I know he's probably got a great case. You can see here the IVUS. We'll play the IVUS back in a second. Ready to play the IVUS, please? So this is the angiogram first. There's the angiogram, which shows we've got really a pristine vessel. And then we'll play the IVUS now. So you can see the IVUS right now, and this is the level of the occlusion right there. And you can see a tremendous amount of luminal gain, little shelf there, but doubling of the lumen right there. So, I mean, that was the area we treated. So I'm very happy with this. We'll check our ABI, TBIs when we get her off the table. But I think we've achieved our goal. We're probably going to stop if it's okay with everyone, and we're not going to stent.
All right. Well, PK, great case, very challenging new area for endovascular procedures.
Thank you, guys. We'll see you soon.